Hello friends, hello everybody, good evening. So how was your test? All set for the Q&A? Yes? Alright. So the audio and the video is all clear. Should we go ahead with the discussion? Alright. So I can see all of you have joined in for the test and discussion. Good evening everybody. And I hope the test was good. There was a mix of questions that I had created for your test. Okay, so let's just have a feedback of what the test involved, right? So there were certain direct questions, right? And I will not be discussing one-liners with you people, right? The reason is that when we are discussing, we should focus more on the clinical aspects, right? Because one-liners and everything, you're going to find all that in the videos also. You will find it in the notes also, right? So all of that is there where you can find one-liners very easily. But the purpose of this discussion is like, no, it is difficult to ask doubts, and doubts arise mainly in controversial areas, mainly in clinical topics, right, where you have studied but you are not able to attempt questions. So this is an opportunity, guys, today that we are going to address those clinical doubts. Okay, so a good mix of questions were there, clinically oriented questions were also there. So we will try to attempt as many questions as possible, and extra pointers also I will give you with each question. All right, so let's go ahead. What did you mark for this? Which of the following is a feature of primary dysmenorrhea, right? Which of the following is a feature of primary dysmenorrhea? So primary dysmenorrhea is also called as what we commonly call as spasmodic dysmenorrhea, right? Very good, right? So mostly you're attempting correctly, right? All of you who have attempted and answered A are correct. So pain is present for the first 48 hours, usually for the initial 48 hours, and then as the flow improves, the pain also improves and later on it subsides, right? So this is spasmodic dysmenorrhea or primary dysmenorrhea, right? And also remember, very important point, that this is generally the girls will present with this complaint. These are young girls, right? Every woman is dealing with primary dysmenorrhea to some extent or the other extent, okay? And very importantly, it will happen a few years after the puberty. Can anybody tell me why? It will not happen in very young pubertal girls who have recently started menstruating. It will happen a few years down the line. Can anybody tell me why? Can anybody tell me why? Second question. Why will it happen a few years down the line after the onset of menses? Excellent, ovulation. Excellent answer, because it is a characteristic of ovulatory cycles, right? Fine. Very good answer. Okay, so anovulatory cycles are typically described as painless, but please remember, if there is anovulation but there is some underlying pathology, cycles can be painful also. Okay, keep that in mind. The most important feature with primary dysmenorrhea is that there is no evidence of pelvic pathology. That is another very important point. There is absolutely no evidence of any pelvic pathology, right? Now, pain begins a week or two before menses, pain persists throughout the menstrual cycle, right? Those kind of pain is secondary dysmenorrhea. Secondary dysmenorrhea, also called as congestive dysmenorrhea. And the most important point is that there is some evidence of pelvic pathology. Some evidence of pelvic pathology, right? So keep that in mind. And very important cause of secondary dysmenorrhea. Can you give me two very important causes of secondary dysmenorrhea? Can you give me the most common cause of secondary dysmenorrhea? Yes, most common cause. Young reproductive age group woman. Young reproductive age group woman. Very good. Endometriosis. PID can also cause secondary dysmenorrhea. So those of you are saying PID, also correct, right? And dysmenorrhea is painful periods. Dysmenorrhea is painful periods. So that is why this is cyclical pain. Okay. So endometriosis. Very good. PID can also cause dysmenorrhea. Now, can anybody tell me another cause of dysmenorrhea plus heavy menstrual bleeding in a woman who is in her 40s? Can anybody tell me that cause also? Adenomyosis. Another is adenomyosis. Excellent answers. Very good. Now, fibroid. Fibroid typically does not cause pain unless there is some complication with fibroid. So, fibroids usually they do not cause pain. Fibroids usually do not cause dysmenorrhea. Fibroids can cause pain, for example, if there is infection of the fibroid, if there is red degeneration of the fibroid, if there is torsion of the fibroid, right? So, these three you remember are certain special situations when fibroid can be associated with pelvic pain, but generally they don't cause dysmenorrhea. Okay. Now, uterine fibroid is not going to be included in adenomyosis. Please don't say adenomyosis is different pathology and fibroid is a different pathology, right? Now, next question. See, 28-year-old unmarried woman is seen in OPD with complaint of dysmenorrhea, painful periods, and dyspareunia. What is dyspareunia? Painful intercourse. Painful intercourse is dyspareunia, right? So, cycles are irregular. On clinical examination, uterus is normal in size and there are tender nodules felt through the posterior fornix. So, when you are attempting such questions, you have to look at keywords. Like for those of you who are attempting, I am very happy to see that you are appreciating keywords like this dysmenorrhea, dyspareunia. These symptoms are keywords, right? And tender nodules through the posterior fornix. They could be endometriotic deposits which are there in the pouch of Douglas, which can be felt through the posterior vaginal fornix. So, the answer here is endometriosis, right? Can there be anovulation in endometriosis? Another question. Endometriosis usually does not cause irregular cycles, but it could. Okay, so please remember this also, extra pointer, with endometriosis, there can be associated anovulation also. And if there is anovulation, then cycles could be irregular. Okay, so keep that in mind as well. Okay, now let's have a look at few important images, image-based questions for endometriosis. Again, very important for you people to remember. So, this is the ultrasound image of a woman who presented with an adnexal mass. See, another point regarding endometriosis, we are talking about endometriosis. Okay. So, apart from dysmenorrhea, point number 1, dyspareunia, point number 2, there is also third point, that is infertility. Okay. So, the clinical context could be like this. An unmarried woman may be, and she is not trying to get pregnant, but she is having dysmenorrhea, that is her main complaint. The second clinical profile could be a woman dealing with infertility. Okay. Now, whenever we have a patient with endometriosis, right, or when we have clinical suspicion of endometriosis, generally the initial investigation to begin with is an ultrasound. On ultrasound, we can see an ovarian, let's say, mass. And very good, right, correctly answering everybody else. This is showing, this is the ovarian mass. This is showing a typical ground glass appearance. Ground glass appearance. Okay. This is very typical of endometrioma. Okay. And this is the same patient's, this is her ultrasound image, then this is the same patient's laparoscopy image, and we can see this cyst in the ovary, and we recognize it as chocolate cyst. Very good, chocolate cyst. Why? Because it is filled with old collected blood and hemosiderin laden macrophages are there, inside. So that is why chocolate cyst it is called. Okay. So very, very important. Identification is important. There can be straightforward image based questions on this also. And what is the gold standard investigation? Why am I showing you all these images? Because the gold standard investigation for making the diagnosis of endometriosis is, and just mentioned, cobblestone feel in PV examination. Yes, now this tender nodules fell through the posterior vaginal fornix. This is sort of a description for that cobblestone feel. Very good. So laparoscopy, excellent. Laparoscopy is the gold standard investigation, right? So we can see these laparoscopic images here. You can see that there is this superficial endometriotic spots can be there, very subtle red flame-like lesions. These are the deposits, fresh deposits that can be there. This is image showing in the pouch of Douglas in the, this image here is showing in the pouch of Douglas on the uterosacrals, okay. And the image on the right here, we are seeing all these blackish nodules. These are fresh deposits, okay, blackish, bluish nodules. And we also have powder burned deposits, right, powder burned deposits like gunshot areas, those sort of things. And these white areas of fibrosis we can also see. Right. So very good. Saying histopath and biopsy, you are right. When we see lesions, when we are doing a laparoscopy and we happen to see these lesions, we are going to take a biopsy from this lesions, right, and send them for histopath. Histopath will show what? Histopath will show what? And or the rest. What will histopath show? What will histopath show if I take biopsy from these lesions? Endometrial glands and stroma. Okay, when I take a biopsy. So, preferably with histopath diagnosis, right? But many times the histopath report does not come as positive. So, histopath is having a positive histopath report is not mandatory, right? So, basically just by looking also we can diagnose endometriosis. So, preferably with preferably with histopath examination, okay? So, endometrial aspirations नहीं करेंगे इसमें, हम आपका क्या करेंगे, laparoscopy करेंगे, okay? So, that is your answer. Now, cystectomy, somebody mentioned preferably cystectomy. Now, see, cystectomy is going to be done if there is treatment of pain required, okay, and medical management has failed. Please remember, always first line treatment for pain is medical management. First we try medical management. If that does not work, then yes, a cystectomy can be done. So for this, please mark, cystectomy can be done, yes, right, if medical management fails and she is not relieved, okay. And cystectomy is preferable to this, fulguration of the deposits and everything, because with cystectomy procedure, there is least risk of recurrence. There is least risk of recurrence. Okay. Now, if the patient is an older woman or completed the family, you are asking what would be the situation then. See, even if the patient is, first of all, endometriosis patients are generally going to be that in that age group of, 20s and late 20s, and they're dealing with infertility and everything. So the clinical profile of an older woman with family completed will generally not be there. But just in case you still want to know that, always medical treatment will be tried first. No, she can have pain relief easily with medical management. So why will we go for an unnecessary surgery, even if her family is complete, even if she is older, right? So that doesn't change. Okay. Now, next question. Which of the following drugs is not used in the management of endometriosis, right? Endometrioma, larger could be surgery. More than 4 centimeter, they say we could go for surgery. 4 centimeter, 5 centimeter, 6 centimeter, 7 centimeter, 8 centimeter, 9 centimeter, 10 centimeter, 11 centimeter, 12 centimeter, 13 centimeter, 14 centimeter, 15 centimeter, 16 centimeter, 17 centimeter, 18 centimeter, 19 centimeter, 20 centimeter, 21 centimeter, 22 centimeter, 23 centimeter, 24 centimeter, 25 centimeter, 26 centimeter, 27 centimeter, 28 centimeter, 29 centimeter, 30 centimeter, 31 centimeter, 32 centimeter, 33 centimeter, 34 centimeter, 35 centimeter, 36 centimeter, 37 centimeter, 38 centimeter, 39 centimeter, 40 centimeter, 41 centimeter, 42 centimeter, 43 centimeter, 44 centimeter, 45 centimeter, 46 centimeter, 47 centimeter, 48 centi right? But still medical management can be tried first. I would say medical management can still be tried first, okay? Not used. Think again. Now, those who are attempting D, yes, and somebody is saying B. Think again, जो D बोल रहे एक बार दोबारा सोचो. Think again, those of you are saying D. Endometriosis is endometrial glands and stroma outside the uterus. Okay. And this is an estrogen dependent condition, right? It is estrogen dependent condition. So why will I give estrogen? To treat the condition which is estrogen dependent, right? So it is not estradiol. So we are not going to use estradiol. That is not used in the management, right? So when we are talking about management of endometriosis, and let's say we are talking about management of pain associated with endometriosis, right? For mild pain, we can go for, NSAIDs also. NSAIDs can be given. Oral contraceptive pills can be prescribed, right? And progesterone therapy can also be given. Progesterone therapy can also be given, right? So medroxyprogesterone acetate. So progesterone therapy can be given in the form of oral progesterone therapy, injectable, or it can be even in the form of Mirena. All of that is fine. Okay. So second line can be progesterone therapy. Second line can be progesterone therapy. That can also be given. Plain estradiol not given. When I say oral contraceptive pills, they are containing estrogen plus progesterone. And all in all, the action on the endometrium is more progestational in action. Okay, keep that in mind. All right. And when we are giving oral contraceptive pills to these women who are having endometriosis, we give them continuously. Continuously meaning we give them for 3 months straight. And then they will be asking, we will ask them to stop taking for a while in between, then they will have the withdrawal bleeding. So we are not allowing them to have menses and periods that frequently. How does that help? You know the answer. How does that help? What is the most common theory? What is the most common theory? Another question of endometriosis. For pathogenesis of endometriosis. Can anybody tell me? What is the most common theory? Very good. Sampson's theory of retrograde menses and implantation. Right. So, when we induce amenorrhea, when we induce by the use of these drugs, when we induce amenorrhea in these women, जब amenorrhea ही हो गया तो फिर no retrograde menses also, right? So fresh seeding of deposits does not happen. So this is the logic of using what? These drugs for the therapy, pain management of endometriosis, right? So now you will remember this point, most common theory, right? Now leuprolide is a GnRH analog. Right, and when we give GnRH analog, these are long-acting drugs, no? So we can give subcutaneously injections. They are depot injections. So when we give those drugs like GnRH analogs, long-acting drugs, right? What do? They cause amenorrhea. That is what they do, no? They work by inducing amenorrhea. So they can be used. Okay, right. And what about clomiphene? What about clomiphene? It can be used in management of endometriosis. Why not? Endometriosis and infertility, right? Don't we try ovulation induction, IUI in women with endometriosis who are dealing with infertility? So clomiphene also has a role, maybe not for pain, but for management of infertility, right? So when we have infertility with endometriosis, what options do we have? We have ovulation induction plus IUI as an option. We have IVF as an option. So we can try ovulation induction IUI for a couple of cycles. If that works, fine. Otherwise, we move to IVF, right? Sometimes patients have been dealing with very long-standing infertility. One may say there is no point in doing ovulation induction IUI. She is very severe endometriosis. Let's go for IVF straight away. So it depends from case to case basis, but these are the two options of managing infertility in a case in patients with endometriosis, right? So even clomiphene will have a role under those circumstances. That's why in this question answer is not clomiphene. So immediately if you think about it, you will say clomiphene, the only place you have read clomiphene is ovulation induction, and where did you read it? In PCOS. So that is the only thing you can think about. No, you have read this in endometriosis also, that with endometriosis with infertility we can give attempts of ovulation induction plus IUI attempts also can be done, right? So answer is estradiol, that is not used in the management of endometriosis. Clear? So now we have recalled all of these important pointers regarding endometriosis. Now, next question. What is the most common cause of abnormal uterine bleeding in pubertal girls? Yes, most common cause of abnormal uterine bleeding in pubertal girls. When we are talking about pubertal girls, answer cannot be A. Endometriosis will not present immediately in a pubertal girl. Okay, endometriosis presents at an age which is woman generally will be in her. I just discussed with you, for endometriosis clinical profile is absolutely different. In endometriosis also, if there is anovulatory cycles, then there can be, abnormal uterine bleeding pattern. But classically, endometriosis presents with dysmenorrhea, dyspareunia and infertility triad, right? So this is not the answer, right? And just before, in the first slide of this lecture, what did we say? We said that initially in young girls, right, when they start menstruating, the initial couple of years, 1 to 2 years, the cycles are anovulatory. This is physiological. The HPO axis is not mature, right? So anovulation is the most common cause. So what is this? This is because of immature HPO axis. Okay, so anovulation is the most common pattern. Now, what is the classical pattern of anovulatory bleeding? Delayed cycles followed by heavy bleeding. If there is a history like this, right, that cycles come late, okay, and whenever periods happen, they tend to be heavy. This goes in favor of anovulatory cycles. This is a very classic pattern of anovulatory bleeding. Okay, keep that in mind. All right. Now, malignancy is not common, obviously, in pubertal girls, right? Bleeding disorder can be there. Right? So, which bleeding disorder is most common in pubertal girls? 20% cases bleeding disorder can be there. Most common in pubertal girls, which bleeding disorder? Anybody? Yes, which bleeding disorder in pubertal girls? Most common? Very good. Von Willebrand disease. Very good. Von Willebrand disease. Now, in older women, which bleeding disorder? In older women, von Willebrand disease congenital, so can present with pubertal girls, right? But in older women, which one? In older women also coagulopathy can be there, and that can lead to heavy menstrual bleeding. But which disorder there then? It will not be congenital. Which disorder there then? ITP, immune thrombocytopenic purpura. ITP in older women. Okay, very good. So this was going to be acquired. That's why in older women it is going to be the acquired type, not the congenital type, right? Very good. Now, next question. Primey at 28 weeks presents with acute abdominal pain. She is a known case of intramural fibroid uterus. She has mild fever, leukocytosis. Uterus is relaxed. On per speculum examination, os is closed. There is no unhealthy discharge. Most likely diagnosis, excellent. All of you answering correctly. This is an often repeated question, old repeat question, PYQ, red degeneration of fibroid. Right? So, very, very important point to remember here, that generally these patients with red degeneration, their main complaint is that of pain. I'll just highlight the important points, okay? So main complaint is abdominal pain. So one could confuse with preterm labor, but it's not preterm labor because the os is closed. Okay. Another important point, generally these patients also tend to have mild fever, and if we send their WBC count, there will be mild leukocytosis also, right? Okay. So there will be mild leukocytosis also, but there is no infection. Please remember, there is no infection. This is an aseptic degeneration. This is also called as carneous degeneration. Okay, so please remember this, don't get confused. So there is no infection. Okay, pain can happen with torsion of fibroid also. I just told you under the circumstances in which fibroids can cause pain, right? So torsion of a fibroid can also cause pain, right? But please remember, this is an intramural fibroid. It's inside the myometrium. How will it undergo torsion? Which kind of fibroid undergoes torsion? Yes, it's not torsion here. Which kind of fibroid undergoes torsion? A fibroid that is hanging by its pedicle, no, isn't it? So it is going to be maybe a pedunculated subserosal, or it could be a pedunculated intracavitary. Very good. Pedunculated intracavitary fibroid. These are the sorts of fibroid that run the risk, or they are at risk of undergoing torsioning on their own pedicle, right? And then yes, it can cause an acute abdominal pain like situation. Okay, so that's why answer here is not torsion fibroid also. Okay. Now, what is the management for red degeneration of fibroid? If they had asked you management, what would be the management? What would be the management? One word answer. What would be the management? Surgery? ये तो pregnancy में हो रहा है. She is pregnant. Yes. Conservative management, right? So what do we do? Very good. Conservative management. In conservative management, what do we give? We'll give her IV fluids, pain relief, right? Analgesia, antipyretics for fever, So conservative management, and watch for signs and symptoms of preterm labor also, right? So preterm labor can get precipitated in these women. So that is why they have to be admitted and observed. Keep that in mind, admitted and observed. Okay, and conservative management. Nothing, no immediate management has to be done for the fibroid. Uterine artery embolization, bache, uterine artery embolized, she is pregnant, right? Pregnant hai na abhi, so how can you go for uterine artery embolization? The uterine artery is feeding the placenta. So, unfortunately, right now, we will not manage the fibroid immediately. We'll go for conservative management, okay? Fine. And patients improve with, so they may have to be admitted for a long duration of time also, they have to be under supervision. And preterm labor can be precipitated, so we take care of that. But nothing much we can do right now at this point in time for the fibroid. Management is conservative. Okay. Next question. 14-year-old girl with primary amenorrhea is diagnosed with Turner syndrome. So this is basically a question right now on Turner syndrome. Which of the following investigation is not required in the evaluation of this girl? Yes. Very good. Very good. All answering correctly. Anti-nuclear antibodies are not needed. So we know Turner syndrome is monosomy X. Right, 45XO is the most common karyotype with Turner syndrome. Remember this, right? And there can be a lot of stigmata associated with Turner syndrome, and that is why a multidisciplinary care approach is needed. See, amenorrhea is one part of her symptomatology, right? Amenorrhea is one thing that she has to deal with, right? But there are other problems also which such females tend to have. They need a cardiac evaluation, yes. Oral glucose tolerance test, yes, is needed. Audiometry is, yes, it is needed. Cardiovascular evaluation, why? Because there can be underlying heart disease, right? Coarctation of aorta, right? And there can be hypertension in these women, right? They are at increased risk of diabetes mellitus also. They are at increased risk of hypothyroidism also. That's why OGTT is also needed. They are also at increased risk of sensorineural hearing loss, and that's why audiometry is also needed in their evaluation, but not anti-nuclear antibodies, right? So look at this image. Okay, this is a image that will help you remember from top to bottom the important stigmata for Turner syndrome. Okay, the most important is short stature. मतलब कि और कोई stigmata हो ना हो, meaning other things may not be there, but they are always and always short stature. This is what we call as the sine qua non, right? This is the most important feature. Most important, most characteristic feature is short stature. Why is there short stature? There is another important question, another question hidden here. There is haploinsufficiency of the SHOX gene. Okay, this is present on the X chromosome, right? And one X is missing here. Right, so this is the reason for the short stature. Other than that, as you can see, webbed neck and low set ears, hypothyroidism, right, wide space nipple, shield chest, cubitus valgus, right, serious anomalies like bicuspid aortic valve. If they ask you most common serious anomaly, answer is bicuspid aortic valve. Apart from that, there can be coarctation of aorta. Okay, renal anomalies can be there, most commonly horseshoe kidney, infantile uterus and external genitalia. They do have a uterus and intelligence is mostly normal. गुरसिफत सिंह मैम इतना FMG में पूछते हैं क्या? आपने recent के papers देखे FMG के पिछले 3-4 साल के? Then you will realize that they are asking you questions on all of these important points. Okay, so intelligence is mostly normal, right? Now, why is there osteoporosis? Long term, there is risk of osteoporosis. Why is there? Primary amenorrhea हो गया, discuss. Primary amenorrhea तो होगा ही ना. What is the reason for amenorrhea here? Huh? It is not given in the image. I am asking you this. What is the reason? Very good. Streak ovaries. Yes, I think that is what you wanted to say, right? So they have the reason for primary amenorrhea is Turner syndrome is a type of gonadal dysgenesis. Turner syndrome is a type of gonadal dysgenesis, right? So they have streak ovaries. And those streak ovaries now are not producing hormones. That's why primary amenorrhea. That's why absent breast development. That's why over her lifetime she will not have the protective effect of estrogen on the bones. So that is why osteoporosis. Right? So what will the management be? Obviously, primary amenorrhea, delayed puberty, yes, the same thing there. So delayed puberty, primary amenorrhea, yeah. So what will be the management be? Management is multidisciplinary. It's not like just look at her reproductive organs and don't look at anything else. Obviously, multidisciplinary approach in management. But now that we're talking about gynae, what can we do about her status? We give her hormone replacement therapy. Yes, hormone replacement therapy, right? And we'll have to give estrogen followed by estrogen plus progesterone. She has the uterus, right? Uterus is present. So estrogen initially for some breast development and then followed by estrogen plus progesterone, right? So not estrogen alone. So keep that in mind that she will need lifelong, very good, she will need lifelong hormone replacement therapy. Okay. Now, next question. 26-year-old woman with BMI 40 presents to the infertility clinic. On physical examination, hirsutism is noted. So, she has infertility, hirsutism, and ultrasound shows polycystic ovaries. So, the diagnosis is PCOS, and what is the best management now? Very good. Weight reduction plus metformin plus ovulation induction with clomiphene, right? So, gonadotropins are second line agents. Gonadotropins are second line agents in PCOS. The reason being that they are costly. Okay, and when we have drugs like clomiphene citrate and letrozole, they can be used. Okay, now why not A? I already told you, gonadotropin are second line agents. So we have the option of trying oral drugs. Now why go ahead and give gonadotropin injectable costly drugs straight away when we can get the desired results and we can have a successful ovulation induction with the help of clomiphene or letrozole. They both are first line drugs. Okay, and the drug of choice is letrozole, right? Now this finasteride, what is finasteride? These are anti-adrenergic drugs, no? Anti-androgenic drugs, sorry. So these anti-androgenic drugs, please remember, anti-androgenic drugs, right? They are for hirsutism. They are for hirsutism, but they cannot be given to women who are wanting to conceive. Think about it. If a woman who is trying to get pregnant, who wants infertility treatment, okay, she gets pregnant and she's kept on anti-androgenic drugs, that's not a good idea. These drugs will cross the placenta and harm the fetus. If the fetus happens to be a male fetus, isn't it? So these anti-androgenic drugs, they are always given along with oral contraceptive pills. The reason is we don't want a woman to get pregnant while on these drugs, right? So in case she is carrying a male fetus, then it can cause feminization of the male fetus, right? So finasteride option is out. You can't give it together, okay? And laparoscopic ovarian drilling is also it's like the last resort, okay? I mean, nowadays laparoscopic ovarian drilling, what we would do is, you know, just burn the ovarian stroma, punch holes, right? Use cautery on the ovary basically, because the stroma of the ovaries is what is contributing to the excess androgens, right? But nowadays with IVF, you know, the utility of laparoscopic ovarian drilling is not that much. So you can remember that yes, laparoscopic ovarian drilling is also something that can be done in PCOS patients to bring down their androgen levels, to help them conceive. But it is something that is not the initial first line treatment also. Keep that in mind. Okay. Now, few important pointers must know about PCOS, right? So, we are burning the theca cells, right? So, when we are doing it laparoscopically, we are basically targeting the stroma. Okay, there is stromal hyperplasia also, na? And when we are doing it laparoscopically, why the utility has also decreased, mind you, come to think of it, we will destroy some follicles in the process, no? When we are doing it laparoscopically, microscopically we are not doing it that we are targeting individual theca cells or stroma, right? So we will destroy some follicles in these women also. So we don't want that. So it is not a first line approach, right? Now what is the criteria? Here, very good. This is called as the Rotterdam's criteria. Quick recall, 2 out of 3 are needed to make the diagnosis of PCOS, right? Menstrual cycle abnormalities can be there in the form of amenorrhea, oligomenorrhea, irregular cycles, clinical and or biochemical evidence of hyperandrogenism, right? So, clinical evidence is hirsutism. Biochemical evidence would be raised serum testosterone, raised serum androgen levels, right? Most importantly, serum testosterone levels, right? So, either of the two can be enough. And ultrasound appearance of polycystic ovaries like this. So, image important for your questions, just image based identification, okay? Now, when I say ultrasound appearance of polycystic ovaries, please remember we are counting these 2 to 9 mm follicles, okay? Initially Rotterdam's criteria said 12, okay? Initially Rotterdam's criteria said 12 follicles, okay? But now it is more than or equal to 20 follicles in either ovary, and or ovarian volume more than 10 ml. Okay, this necklace appearance, string of pearl appearance, they are all describing the appearance of how the follicles are arranged in the ovary. What is important is the number of follicles according to the Rotterdam's criteria. Okay, so yes, necklace appearance seen. Yes, string of pearls appearance seen. Yes, stromal hyperplasia on ultrasound seen. But they are not part of diagnostic Rotterdam's criteria. Okay, they are not part. These are seen. Yes, but not part of criteria. Okay. Now, confusing with theca lutein cyst. See, an ovary which has got a theca lutein cyst, multiple cysts in the ovary, okay, will look similar. But the clinical profile is what will be different. Please keep in mind, okay. Clinical profile of PCOS will be different. A young woman with menstrual cycle abnormalities, and these menstrual problems have been ongoing from, the time of puberty only, right? Clinical profile will be different. Theca lutein cysts, where do you see? Where do you see theca lutein cyst? In molar pregnancy, isn't it? Clinical profile different. Okay, so many times your image based questions, either they have to be very classic or they will come with some sort of clinical profile which will go along with, which will help you make the right choice for the answer. Keep that in mind, right? Now let's also look at the other pointers. LH-FSH ratio. LH-FSH ratio is more than 2:1. Very good on day 2, day 3. You are a bit confused in PCOD as to why it is happening because of lack of progesterone. In PCOS, lack of progesterone. See, the main problem with PCOS is two things: androgen excess from the ovaries, and the second thing is insulin resistance, right? All of this altogether is contributing to anovulation as the problem. Okay. Now, when anovulation will happen, there will be no corpus luteum, therefore no progesterone. Okay, therefore no progesterone. So, lack of progesterone, low progesterone is a consequence of anovulation. It's happening because of anovulation. PCOS is not happening because of low progesterone. Got it? And like that, acanthosis nigricans, very good. Now, acanthosis nigricans, please also remember, is a feature of acanthosis nigricans It is not necessary that acanthosis nigricans will be in all women with PCOS, but it means or it signifies, it points towards underlying insulin resistance, signifies underlying insulin resistance, right? The dark velvety pigmentation at the nape of the neck, it can be under the breasts, it can be in the axilla, it can be seen in the medial aspect of the thighs. So this is basically signifying underlying insulin resistance. Okay, LH-FSH ratio more than 2:1. Again, it is not diagnostic. It is not diagnostic. What about the sex hormone binding globulin levels? Please remember, this is very, very important. Highlighted sex hormone binding globulins are decreased. What about serum AMH levels? What about serum AMH levels? What do you think happens to the serum AMH levels? Yes. Low? They have so many follicles. They have, I am telling you, these are 2 to 9 mm follicles which are being measured. There's so many follicles, right? So it is increased. Serum AMH levels are increased on the higher side in such women, okay? Generally more than 5 nanogram per ml. Okay, the first line management is lifestyle modification and weight reduction is encouraged. Whether a woman wants to conceive or whether she doesn't want to conceive, it doesn't matter. They will need lifestyle modification, right? Now, women who are not wanting to conceive, what is the drug of choice? Oral contraceptive pills. Okay, first line drug for hirsutism in PCOS, it is oral contraceptive pills. Keep that in mind. For ovulation induction, then the drug of choice is letrozole and clomiphene. They are different class of drugs. Letrozole and clomiphene are different class of drugs, right? But they work by increasing FSH secretion from the pituitary ultimately, right? And that is why they promote follicular growth. That is how they work, bottom line. So both are first line, but if you have to pick one, letrozole is a better answer than clomiphene citrate if you have to pick one. What about metformin? Metformin itself, by itself, has no role in reducing the androgen levels. By itself, it has no role in causing ovulation or helping ovulation, but it works as an insulin sensitizer. Okay, but it works as an insulin sensitizer. So it's not necessary that we give metformin in all women. If she has features of insulin resistance, then we tend to give this metformin also in managing these patients. Okay, so remember this very, very important point. Now, also remember, and this was asked in your FMGE examination, July 2023. I recently was making this paper for you and I wanted to figure out how many questions on PCOS have been asked. They ask you multiple questions on PCOS many times. This is a very, very favorite topic, right? So, there are certain tests which are done, right? Like you can go for a hormonal profile, you can check the serum AMH level, right? But most important part of diagnosis is serum testosterone. Most important hormone that is part of the diagnostic criteria is serum testosterone. So we check the serum testosterone levels also. Right? Now, there are long-standing complications that can happen in PCOS women. Remember, they have risk of metabolic syndrome. They have risk of, diabetes mellitus also. Right? So, now we also want to go for a lipid profile in these patients. We also want to go for a lipid profile, right? We want to check their baseline OGTT also. So, long-term care is also needed. So, at the outset, baseline lipid profile, baseline OGTT, check their BP, take a proper history, look at their lifestyle factors, look at if there is, any evidence of metabolic syndrome in them or not. So, keep that in mind, right? Now, echo, क्यों चाहिए echo? है ना? अभी से क्यों चाहिए echo? अगर if there is something in cardiac evaluation, then, right? But for now, no. I think basic baseline test, good enough. Lipid profile, OGTT, checking the BP, a baseline, general checkup is good enough. Okay? So, that much we do. All right. Now, tests for insulin resistance, they are not routinely done. Okay, tests for insulin resistance can also be done, but clinically, routinely, in every patient, we don't do it. Okay, chalo. So, important pointers regarding PCOS done. Next question. 47-year-old woman with amenorrhea for 1 year had FSH levels of 40. On 2 occasions, she is complaining of hot flashes also, otherwise healthy. She started on systemic HRT. What is true about HRT? What is true? Very good, all of you. It decreases the risk of colon cancer. First of all, there are important pointers you will remember from this question itself, right? That if you want to make the diagnosis of menopause, okay, it's a retrospective diagnosis, isn't it? Menopause is a retrospective diagnosis which is made after 12 months of amenorrhea. After 12 months of amenorrhea in a woman in expected age. First point, remember that, in expected age of menopause. Okay, let's understand this one point, right? See, if a woman is in that age group in which menopause generally sets in, right? Like for our mothers, let's say, for our grandmothers, let's say, right? Nobody diagnosed their menopause for them. It happened, right? It's a retrospective diagnosis. After 12 months of amenorrhea, we say menopause has set in, right? FSH levels are needed to make the diagnosis if she's not in that expected age. Okay, so if you want to make the diagnosis of menopause using a hormone, which hormone will you use? And they will ask you this question, right? They will mention FSH, they'll mention LH, they'll say estrogen, they'll say progesterone. I mean, they can give you 4 options like this. If you have to pick one, so diagnosis of menopause using which hormone? FSH. Very good. So, FSH will make the diagnosis, right? More than 40 on 2 occasions, at least 1 month apart. Very good. This is how you will remember. So, please remember that LH levels are also increased. Gonadotropin levels are also increased after menopause. Serum estradiol levels are also low. Less than 20 picogram per ml is the menopausal level. Agreed, right? All of this will happen. Serum AMH level will also decrease. All that will happen. But you have to pick one hormone. It is serum FSH. That is your best answer. Keep that in mind. Okay. Now, what is true about, and another thing, she is getting systemic HRT. Systemic HRT meaning that we are giving her hormone, maybe oral, maybe injectable, whichever, but we are giving systemic HRT, right? The most important indication of HRT is hot flashes. Most important indication and most common indication for hormone replacement therapy in postmenopausal women. So, hot flashes or vasomotor symptoms, right? Keep that in mind also. This is another MCQ pointer, so highlight it. Highlight that point. Now, what is true? It does not decrease the risk of breast cancer. In fact, it increases the risk of breast cancer. Right? It decreases the risk of endometrial cancer is also not correct. These are postmenopausal women we are talking about. We obviously give estrogen along with progesterone in those women where uterus is present, right? And progesterone we give for endometrial protection. But any form of estrogen is in the therapy. So, risk of endometrial cancer is not decreased. Keep that in mind. Okay. Now, does it increase the risk of osteoporosis? No. We are giving estrogen, so it is going to be protective against this thing, right? Now, Ayush, how does it decrease the risk of colon cancer? They say that the reason that it decreases the risk of colon cancer is because of action of the estrogen receptors on the colon surface also, and also because of the anti-mitotic effects, right? So something to do with the action of estrogen on the receptors. Okay, so that is the reason. So that is how it decreases the risk of colon cancer. Okay, we will come to the causes of endometrial cancer in subsequent questions. Okay, so the answer, estrogen or ER beta receptors promotes apoptosis. So there's your answer, right? So please remember the advantages and disadvantages of HRT in one place, and that will answer all your questions that you are putting in the chat box right now. I'm seeing, right? So it gives relief from hot flashes, relief from genitourinary atrophy symptoms also, but the main reason that we are starting is for this. Please remember, this is the main reason for giving systemic hormone replacement therapy. Okay, it will help prevention of osteoporosis also. It will decrease the risk of colon cancer. These are the 4 main advantages. Please remember that. If they ask you drug of choice for osteoporosis, yes, you will get the PDF. If you ask drug of choice for osteoporosis, it is osteoporosis that is already there, bisphosphonates. Okay, please remember this also. Now, the disadvantages of systemic HRT: increased risk of coronary artery disease, but very, very important in older women. In older women. In older women. By older, I mean who have 10 years down the line, postmenopausal. Generally women who are, let's say, in their 60s or something, right? And most women who are initiating or starting postmenopausal HRT for the first time will not be that old, right? So keep in mind that when you have early initiation of HRT for symptoms like hot flashes, coronary artery disease nowadays is not much of a concern, but yes, increased risk is there in older women. Risk of breast cancer definitely there, risk of venous thromboembolism, risk of endometrial cancer, ovarian cancer and gallstones. But the most important are these. I'll just highlight. Most important are these, top 3. Okay. Now, also please remember, yes, when we give systemic HRT, we are giving for relief from hot flashes. It will also provide relief from genitourinary atrophy symptoms. But let's say a woman is postmenopausal and she has vaginal dryness. That is her only complaint. She has atrophic vaginitis. That is her only diagnosis. She doesn't have hot flashes. Then there is no need to give systemic HRT. Then what do we give? Then what do we do? Then what is the treatment? Yes. Then what is the treatment? Local estrogen cream. Very good. Then local estrogen cream. Then why to give systemic HRT and take all the disadvantages of systemic HRT? Right? Then there is no point. Okay? Chalo. Next question. 18-year-old unmarried girl presented with complaint of 2-month amenorrhea and a fainting episode. This is a PYQ from your FMGE exam, okay? Her physical examination is normal, vitals are stable. What should you do next? Excellent. Excellent. We should immediately go for a urine pregnancy test. Married, unmarried, doesn't matter. Says sexually active, does not say sexually active, whatever, right? If it's a reproductive age group woman, there is amenorrhea, check for pregnancy. In this particular situation, a history of fainting episode, okay, a history of fainting episode could point towards the possibility of ectopic pregnancy also. Right, but yes, her initial physical examination is normal, vitals are stable, but she could be an ectopic pregnancy also. We don't know. It could be a pregnancy associated complication. We are not going deeper than that. Ectopic I will discuss with you under obstetrics, right, in detail also. So for now, you have to rule out pregnancy. So UPT needs to be done. Right, and it is something that you will do in emergency and you will see the report immediately. right? So that is going to be the first investigation, but yes, you will go ahead with TVS also. It's not like that you will not do an ultrasound. You will do an ultrasound, okay? You will do an ultrasound, but for now, they're asking you what you should do next. So, your immediate next step has to be a urine pregnancy test, okay? Now, let's see another question here. OC pill increases the and decreases what cancers? So I'm just writing in this slide because this is the slide available to me. OC pills increase the risk of which cancers? Anybody answering? OC pills increase the risk of which cancer? Cervical cancer, and that is adenocarcinoma of the cervix, not squamous cell cancer, adenocarcinoma. What else? Hepatic adenoma. Please remember, OC pills are protective. Protective. Adenomas are anyways benign. Adenomas are anyways benign. Protective for endometrial, protective for ovarian, and protective for colon cancer. Okay, fine. No increase or decrease risk of hepatocellular carcinoma. Okay, ठीक है, right? No increase or decrease risk of hepatocellular carcinoma. Breast cancer, controversial. Yes. So, OC pills, they either don't increase the risk of breast cancer, or in certain studies, they have been shown to contribute to a slight increase in risk. And there are studies that are saying that OC pills, they don't increase the risk of breast cancer also. So, I will put it here plus minus. We have studies on both sides of the spectrum. So, if you get a question like this where you have to cherry pick, please remember at least that it is protective for these. Remember, you'll have to remember these pointers and you'll have to see what those 4 options are like. So, accordingly your answer will change. Breast cancer plus minus I will say, because yes, there are studies showing that there is no correlation, no increased risk, because nowadays we are using low dose oral contraceptive pills. So, those earlier studies where increased risk was seen, that was when we were having high dose oral contraceptive pills. So, nowadays with low dose, certain studies saying slight increased risk, some studies saying no increased risk. So, it's plus minus. Okay. Right. Next question. Which of the following characteristics is not responsible for Ferning pattern of cervical mucus? Yes. This fainting episode, is it indicative of rupture? It could. Fainting episode could be indicative of rupture. Yes. Yes. So, I am getting multiple answers, options from you people. Not responsible for Ferning. Ferning happens because of estrogen mid-cycle, right? So, high estrogen around mid-cycle, right? And under the influence of estrogen, there is low protein and high sodium and chloride concentration in the cervical mucus. So, high progesterone is not responsible for Ferning pattern. A, C and D options are correct. Okay. Right? ये proliferative phase, yes, it is around the time of mid-cycle. So, mid-cycle के बारे में हम separately बोलते हैं ना. So, characteristic Ferning is seen around mid-cycle when estrogen levels are also very, very high. They are peaking around that time. Okay, fine. So, please remember these features, right? Estrogen and progesterone. Right. So, please remember, if you look at the action on endometrium, right. So, proliferative changes with estrogen and secretory changes with progesterone. Okay. When we say secretory changes, another question. What is the first secretory change on histopath? What is the first secretory change on histopath? Yes, secretory change. Yes, on histopath. Basal, subnuclear vacuolization. Right? So proliferative change में आ गया ना endometrial gland proliferation. Right? Endometrial menses हो गया, menstruation happened, all the endometrium has been shed. Now comes the proliferative phase of the cycle. So endometrium will build up, glands will proliferate, right? Secretory changes will happen later under the influence of progesterone. The first secretory change is basal or subnuclear vacuolization. Keep that in mind. This is also an MCQ that has been asked. Effect on the pregnant uterus. On the pregnant uterus, estrogen is responsible for the growth of the pregnant uterus. Estrogen is responsible for the myometrial hyperplasia that happens. Please keep that in mind. Myometrial hyperplasia and hypertrophy that happens. Okay? And progesterone is responsible for decidualization of the endometrial lining during pregnancy. On cervical mucus becomes thin and stretchable. That phenomena is called as spin-Barkey. On this also question has been asked. Okay? And cervical mucus becomes thick and breaks apart under the influence of progesterone. Okay, progesterone causes thickening of cervical mucus. This phenomena is also called as TAC. Okay, now action on fallopian tube is less commonly asked, right? So you can leave this also. But action on breast, yes, questions are asked on this. Very, very important, right? So estrogen is responsible for duct development and progesterone is responsible for glandular development. But only after estrogen priming. So please remember, this question has been asked in some form or the other. Estrogen is responsible for duct development. Progesterone is responsible for glandular development, but only after estrogen priming has also been there. Fern-like is not the same as spin-Barkey. Spin-Barkey is that if I take the cervical mucus in between my fingers, it becomes thin and stretchable. Ferning one has to see on the microscope. So we take the cervical mucus, spread it on the glass slide, let it dry and then observe the ferning pattern. Cervical mucus dries in the fern-like pattern which can be appreciated under microscope. That is ferning, right? They happen to have the same time around mid-cycle. They happen to because of estrogen, but they don't mean the same thing. Okay? Now, another important question, effect on growth. So, the initiation of growth spurt at puberty is because of estrogen, but eventually estrogen causes epiphyseal closure. Please remember that. Okay. So, estrogen has a role there in initiation of growth spurt at puberty. But growth के लिए obviously growth hormone is also going to be responsible. Eventually, yes, closure of epiphysis happens because of estrogen, and progesterone has no effect on the growth at puberty, right? And coagulation, again, the hypercoagulable state during pregnancy is because of estrogen, and progesterone has got no effect on the coagulation. Okay, right? Now, let's have a look at the next question. Which of the following peak is responsible for resumption of meiosis in the primary oocyte? Now, there are many things that I will tell you on this chart itself, on which questions have been asked. They could ask you, which of the following peak is responsible for ovulation? Just prior to ovulation, resumption of meiosis happens. Just prior to ovulation, resumption of meiosis happen, right? Same hormone is responsible. Which is that hormone? LH is responsible. right? So which is the LH surge here? Day 14 is the ovulation in a woman who is having 28-day cycles, right? So here is the ovulation. So which is this surge responsible? Peak 3. LH surge is responsible. What is responsible? The third peak is responsible. The LH surge is responsible, right? What is this here? The blue graph here. The blue graph here, one is the FSH. The green graph here, the one in green here is estradiol. And this 4 here is progesterone. This 4 here is progesterone. Okay. Another thing that you need to remember is, as you can see here, that this is LH peak. And then this rise in LH that is happening, that is LH surge. Ovulation is happening here. So they have asked this question also. They have marked this arrow and they ask you what event is happening here. So ovulation is happening here. Please remember that. So this is one important pointer that you should keep in mind. Then you can see that LH peak happens or LH surge happens. This is LH surge. LH has started to rise, that is LH surge. And then peak LH levels are obtained. So they ask you about timing. Another question they ask you about is timing. Very, very important. So LH surge occurs how many hours prior to ovulation? 36 hours prior to ovulation. And LH peak, okay, right, LH peak occurs 10 to 12 hours prior to ovulation. Okay, and please remember, estradiol peak happens first and then LH peak happens. Okay, so this sequence is also important. So it is estradiol peak and then LH surge. Please keep in mind. And it is after ovulation that progesterone will come into the picture, because progesterone will be secreted by corpus luteum. Right? Right? So this will happen in the second half of the cycle, like secretory. So this is proliferative phase here. Right? This is the proliferative phase. This is the secretory phase. This is progesterone, I told you. This is around mid-cycle. So LH surge is happening around mid-cycle because this is ovulation happening. So many things you will remember. Okay, you can see that this is estradiol peak I was telling you about. This is happening somewhere around here. Day 10 of the cycle, isn't it? So peak estradiol levels, estradiol peak is happening somewhere around that time. And very, very important question, peak secretory activity. They ask you peak secretory activity. They ask you peak progesterone levels. When is that happening? Here, day 21. Day 21 of the cycle. Approximately 7 days after ovulation. Approximately 7 days after ovulation. Right? Is the peak secretory activity, is the peak progesterone levels, right, around day 21 of the cycle. This is another thing that you have to remember. Another thing that you will keep in mind from this graph itself, if I have to check for ovulation and I have to check serum progesterone levels, which day of the month I will call her? I will call her on day 21 of cycle, because that is when I am expecting peak progesterone levels, isn't it? Right? And peak progesterone levels or progesterone will come in the serum only after ovulation, isn't it? Peak levels will come only after ovulation. So I can check for ovulation by checking the serum progesterone on day 21 of the cycle. Right? And somebody mentioned, yes, another important thing. In a woman with 28-day cycle, ovulation is happening on day 14. Which phase is fixed? This secretory phase is fixed. This duration is fixed. Because the lifespan of corpus luteum is fixed. Lifespan of corpus luteum is fixed in the non-pregnant state. It is about 10 to 12 days. In the non-pregnant state, it is about 10 to 12 days. So, the duration of secretory phase or the duration of luteal phase, because corpus luteum is producing progesterone and that is leading to secretory changes. So, duration of luteal phase is fixed, 14 days. That is the convention. That is the convention. Okay. So, for a woman who's having 28 day cycles, every 28 days she has periods, then her ovulation day would be, what will be her ovulation day? Day of ovulation can be predicted. How? Cycle length minus 14. So, 28 minus 14. That would give the cycle length. Okay. Fine. Alright. So, for example, if a woman has 32 days cycle, every 32 days she is having her menstrual cycle. So, her day of ovulation would be 32 minus 14. Okay. That will be the day of ovulation. Alright. If somebody is having irregular cycles, then what? If somebody is having irregular cycles, then what? If somebody is having irregular cycles, if a woman tells you that my cycles are irregular, there is no pattern. Sometimes it comes in 3 weeks, sometimes it comes in 4 weeks, sometimes it comes in 6 weeks. There's unpredictable. Irregular cycles. What does that mean? Very good. That in itself means that she is not ovulating regularly. That means her cycles are anovulatory. Okay. Next question. Which of the following is not estrogen dependent pubertal change? Yes. Not estrogen dependent pubertal change? Yes. Very good. Hair growth. Hair growth is androgen dependent. Androgen dependent. Very good. Right. So, menstruation obviously has to be estrogen dependent because estrogen is the one that is going to cause proliferation of the endometrium. Right. Vaginal cornification. What do you mean by vaginal cornification? What is vaginal cornification? What does it mean? Recall, vagina has stratified squamous epithelium. Okay. Now, there are layers of that epithelium. On this also question has been asked. So, superficial cells in the vagina, they predominate under estrogen effect. Okay. So, these superficial cells have, they have basically a small pycnotic nucleus. They appear red also. Right. So, superficial cells in vagina, keratinization थोड़ी cornification, यहाँ पे keratinization की बात नहीं हो रही है. vagina में keratin कहाँ है? Keratin is in the skin, the overlay, the vulva is keratinized epithelium. Vagina is stratified squamous, but not keratinized. Okay. So, when cornification we are talking about here is the presence of superficial cells in the vagina, that is estrogen dependent. Okay. And progesterone dominant cells are the intermediate cells. Okay. And cervical mucus changes we just discussed. Alright. Next question. 14-year-old girl comes with the complaint of primary amenorrhea. She is tall and has well developed breast. What is the treatment given to her? Also an FMG previous year question. Also an FMG previous year question. Okay. So, most of you are saying correct that there is no need to give any treatment. Overall, she is only 14-year-old. She is tall also, height is not an issue. She has well developed breast also. She does not qualify for workup. No, we can still wait another year in the presence of breast development. 15 years we can wait. So, there is no need to give any treatment right now if secondary sexual characteristics are present. Obviously, estrogen we will not give. This is out, ADH, out of the blue option, absolutely incorrect option, no role here at all. And GnRH analogues is something that you give for precocious puberty, right? So, GnRH analogues, where is it used? For precocious puberty. By GnRH analog is going to cause down regulation of pituitary. It is going to cause ovarian suppression of hormone production, ovarian suppression of hormone production. So, in any situation where we want the ovaries to not secrete anything, that is where we give GnRH analogues. Like for example, in precocious puberty, right? So, then we give, otherwise there is no role, right? Now, next question. A 15-year-old is brought in by her mother in emergency with acute urinary retention. Okay, how much score is good for this test according to you? See, I'll tell you what. When I made this test, my goal was not to test you in the sense that how much you are scoring so you are a good performer. The goal is, honestly, when I set this test paper, my goal is that you start thinking, okay, that you start recalling the important areas, okay, that you get an idea of what sort of previous year questions are asked, okay. These are the best questions that have been chosen to represent the entire syllabus so that we are able to cover all that is maximum, right. So, this test is not to rank you based on your marks. This test is not to tell you that, you know, if you score this much, then it is going, then you are getting selected. No, the goal of this test for right now is to highlight areas which are important, to help you identify which topics you need to read more, to help you understand, especially when clinical questions are involved, not to discourage you or not to tell you that you have not read, but to tell you that howsoever you may have read will be enough if you just see how to attempt the questions, okay. So, this is an opportunity where you are going to learn and understand, especially questions like this, how we read through the question, how we are going to look at the keywords, okay, fine. So, that is the goal. So, don't worry about your score, alright. For now, you worry about your score later when you give grand tests, like for example. But in a subject-wise test, the analysis of the paper is what is more important, right? Now, a 15-year-old is brought in by her mother in emergency with acute urinary retention. On abdominal examination, there is a suprapubic bulge and a lump abdominal arising from the pelvis. All of this is nice story, but you see here, local examination following findings are seen. So, what do you see here? You see a bulge here at the introitus. Okay, now see, bluish bulge they describe. Students tell that exam mein wo bluish bulge, it is not that appreciated, right? But there is something at the introitus, okay. Behind that, obviously there is collected blood, so it does have a bluish tinge. But sometimes there are patient pictures, you may not be able to appreciate it. Then the clinical profile matters, right? On questioning, the mother says that she has not yet attained menarche. 15-year-old girl, primary amenorrhea, bulge at the introitus. This is imperforate hymen. So, you read quickly and you rule out the other options, right? You will think, okay, let's say, is it fibroid uterus? You may say there is a lump arising from the pelvis, so maybe it is a fibroid uterus. No, this lump, what is this lump? Okay, what is this lump that is arising from the pelvis? What is this lump that can be felt on per abdominal examination? Because this blood is collecting, no? This blood is collecting, hematocolpos, hematometra, hematosalpinx maybe. So, it is all gone big. So, that is what this lump is, right? So, definitely yes, lump can be there, right? Because these are hidden menses. This is what cryptomenorrhea, hidden menses, no outflow of menses. So, history of cyclical abdominal pain is there. Why is there urinary retention? Why is there urinary retention? Look at this. There's a lump, there's something filling up the entire vagina that is pushing, there is urethra in front that is getting compressed. So, episodes of urinary retention are also there. So many extra things you learn, right? So, answer is imperforate hymen, not fibroid uterus. Why is it not transverse vaginal septum? Transverse vaginal septum may, the septum location, transverse vaginal septum is not the answer. Why? Because generally the transverse vaginal septum is higher up, right? So, here if they are mentioning a bluish bulge at introitus, it's imperforate hymen. It's not transverse vaginal septum. Mullerian agenesis. Mullerian duct gives rise to uterus. If uterus is absent, there will be nothing collecting inside or anything. So, this is not Mullerian agenesis. Okay, fine, all right. Now, picture is looking like Gartner's duct cyst. Just by looking at the picture, what bulge it is, if it is typically not blue like I told you, then obviously things can be different, right? But Gartner's duct cyst is not going to look like this, and if they had to show you Gartner's duct cyst, they would maybe show it with a speculum, a swelling arising from the anterolateral aspect of the vagina. They would go more classical pictures and not a clinical profile like this. Until and unless there is a very classic textbook picture, okay, most of the pictures come with a clinical setting. So, don't worry about that. Okay. Now, what is the keyword for transverse vaginal septum? Okay. I'll just use the other image. Just use some space here. Okay. If it is a transverse vaginal septum, okay, the way to differentiate on clinical examination is that there is going to be, let's say if this is the rectum, okay, and we do a per rectal examination, supposing, right, there is going to be this bulge on per rectal examination, bulge on per rectal examination along the entire length of vagina, right, in imperforate hymen, right, because imperforate hymen location is here at the introitus. So, this whole collection is happening, no, along the entire length of the vagina. But with the transverse vaginal septum, the clue that they will give you is local examination is normal, there is no bluish bulge at the introitus, and वैसे तो transverse vaginal septum can be anywhere along the length of the vagina. It can be in the lower part also, it can be in the middle part also, it can be in the upper part of the vagina also. Mostly it is in the upper part. So, if they have to frame a question regarding transverse vaginal septum, the clue that they tend to give you or they should give you is transverse vaginal septum, they will say local examination normal, right, and they will say this bulge on per rectal examination is in the upper part. That sort of an information, clear cut information they should be giving you. Okay, fine.